In regards to positioning, a high thigh tourniquet, lateral hip post at the level of the tourniquet, a foot bump, and lateral wedge allow for resting knee flexion of 90 degrees. On the pre-op MRI, note the position of the popliteal artery at the level of the tibial footprint of the PCL, as 3% of patients have an aberrant anterior tibial artery that lies anterior to the popliteus muscle. A full-size fluoroscopic unit should be available and come in from the ipsilateral side. Preoperative exam under anesthesia to assess for concomitant ligamentous injuries and posterior jaw test is performed. An arterial Doppler assessment is performed bedside of the posterior tibial and dorsalis pedis arteries. Two individual semitendinous allografts or autografts of choice are used for the anterolateral and posterior medial bundles. The anterolateral bundle graft is prepared to 9 to 10 by 70 to 90 millimeters. The posterior medial graft is folded over, whip stitched, and prepared to 6 to 7 by 70 to 90 millimeters. Dual suspensory fixation on both the femoral and tibial side is imperative as it allows for sequential tensioning of the grafts. The anterolateral bundle femoral side is prepared with a tightrope ABS and internal brace, while the posterior medial bundle can be prepared with or without an internal brace. The tibial side of each graft is prepared with a tightrope ABS. With the knee in 90 degrees of flexion, use an arthroscopic burner and shaver to clear out the footprint of the native PCL. Leave some tissue to help identify the femoral origin of the PCL. Use a modified Gilchrist maneuver. Place your arthroscope in the posterior knee from the anterolateral portal. Switching to a 70-degree scope if available may help with visualization. If all PCL work will be done through the anterior portals, it is recommended to make a high and long anterior medial portal. With the eyes of the camera facing medially, an 18-gauge spinal needle followed by switching stick and threaded cannula can be inserted just proximal to the posterior medial capsular fold, aiming towards the tibial PCL remnant. Keeping this portal proximal and high ensures the posterior medial portal is not too close to the femoral condyle, which would inhibit instrument freedom of movement. With the camera in the anterolateral portal, a 90-degree electrocautery is used to clear a soft tissue plane between the posterior midline septum and the posterior horn of the medial meniscus. This allows the neurovascular structures to relax posteriorly and allows for better visualization. Take care to not resect or violate the shiny white fibers of the posterior horn of the medial meniscus. Use a shaver and electrocautery to clear out the PCL tibial footprint until it drops off in the back of the knee. It is imperative to visualize the popliteus muscle and the mammillary bodies, which lie on either side of the tibial PCL. Once you delineate the tibial footprint, move your 70-degree scope into the posterior medial portal, have the tibial PCL guide set to 60 degrees, place the tibial PCL guide through the anterior medial portal and hook the base of the PCL facet, then drop your hand. Fluoroscopy confirms the correct sagittal position and the arthroscope confirms the correct coronal position of the PCL guide. Placement of the fluoroscopic monitor adjacent to the ipsilateral shoulder of the patient allows the surgeon to see both the fluoroscopic and arthroscopic views simultaneously. A 2.4mm guide pin is drilled under fluoroscopic guidance with a 70-degree scope in the posterior medial portal, followed by a 3.5mm flip cutter. After visualizing the flip cutter in the posterior knee, detach the tibial guide from the bullet and use the guide itself to retract the posterior capsule and protect the neurovascular structures. Drill an appropriately sized tunnel at least 35mm in length. If concerned about graft tunnel mismatch, drill a longer or full-length tunnel. Different colored shuttle sutures are passed. Drill the anterolateral bundle first, as this is the larger and more important limb for posterior knee stability. Femoral drilling can be done either outside in with a flip cutter or inside out with a standard reamer. Tunnel lengths should be drilled 15 to 20mm. If done outside in, the arthroscope should be placed in the anterolateral portal. Place the guide at the anatomic origin of the anterolateral bundle, abutting the cartilage margin through the anterior medial portal. Set the femoral guide to 55 degrees with an orientation 20 degrees anterior to the transepicondylar axis and the axial plane of the distal femur. For the posterior medial bundle, ensure the tunnel is more posterior than the previously drilled anterolateral bundle tunnel with similar principles. With the arthroscope in the anterolateral portal, a 12mm passport cannula is placed in the anterior medial portal. At this point, suture management using different colored passing sutures or clamping your passing sutures with different clamps is critical to limit errors with graft passage. Our preference is for each graft to be passed into the tibial tunnel first, followed by the femoral tunnel. However, this can be done per surgeon preference. The posterior medial graft is passed first to the anterior medial portal, as this will allow it to seat in the anatomic medial aspect of the tibial tunnel. The graft is then bottomed out in the femoral tunnel. The anterolateral bundle graft and internal brace is passed next. The arthroscope is removed and the knee is cycled. The femoral side of the grafts can be fixed with cortical buttons. On the tibial side, tension the anterolateral bundle in 85 to 90 degrees of knee flexion with an anterior drawer, and the posterior medial bundle in 10 degrees of knee flexion. Observe tibial reduction in relationship to the femur under fluoroscopic guidance prior to final tensioning. The swivel lock anchor can be used as backup fixation in the tibia for the internal brace. A posterior drawer test is performed to assess construct fixation. Final range of motion is evaluated prior to final tensioning and closure. The tourniquet is deflated and arterial Doppler studies are performed in sterile fashion to rule out arterial injury. After surgery, the operative extremity is placed in a hinged knee brace, locked in extension. The patient is made non-weight bearing for 2 weeks and advanced to toe touch weight bearing for 4 additional weeks. Early emphasis is placed on quadriceps activation and prone passive knee range of motion. At 2 weeks, if swelling permits, the patient can be transitioned to a custom dynamic PCL unloader brace, as shown, to be worn always except for bathing for a total of 9 months postoperatively. If range of motion plateaus, brace discontinuation may be required to prevent arthrofibrosis. We recommend no active hamstring firing for a minimum of 4 months postoperatively. At 6 months, the patient may graduate to a progressive jogging program.